Good morning. Thank you, Murli, for involving me in this instruction course. I was to cover preoperative evaluation, critical period assessment, and aiming at surgical intervention. So, when you're talking about pediatric corneal opacities, one has to take a holistic view because patients don't come with isolated problems. And as we do know that there are several more hurdles in the management, Dr. Sushmita had also covered how there's so many EUAs which would be required, examination, follow-up, and so on. So essentially, when you're looking at the intervention, learning period, pre-operative assessment, etc., one is looking at the anatomical success, one is looking at vision, but as far as vision is concerned, it's the practical vision that we're looking at. We're not, some of them with the congenital opacities, we're not going to be aiming for 6/6 unaided vision. The aim in the initial stage is to give them adequate vision, to have at least their visual system develops, and then depending upon the situation, you will plan your intervention. Not to forget the importance of binocularity, stereopsis, and of course the comfort and follow-up. All of this needs to be taken into account when planning your intervention. And also it requires sometimes multi-system or interdisciplinary approach. There could be, whenever we are dealing with a corneal problem, there's associated problems related to the cataract, whether to operate or not, whether it's a dense cataract, whether it's a minimal cataract. Sometimes there may be just be an anterior polar cataract, and often some people would say, oh, this should be removed. But there's a small anterior polar cataract, the rest of the lens is clear, it may be better to leave it alone. In addition to that, whatever intervention you do, there is an associated refractive error. So careful refraction, prescription of glasses, and occlusion. These children are very prone to trauma and infections, as are all children. So there again, one needs to counsel and take that into account into whatever intervention you do. Strabismus and amblyopia, and then the corneal opacities. All of this needs to be taken into account when planning the intervention. The other important thing is that not all patients can come for follow-up, and also getting the information out there to get the people coming early. So here somehow we need to see, because often we still do get patients coming quite late, and they go from center to center, and they often do not present so early. So this is important. And then the tertiary care, of course, would be surgery, shared care, and follow-up. So of course we do know that success can be great, and several people where earlier they felt that pediatric keratoplasty has a very dismal prognosis. With the modern knowledge that we have, one can have good vision even with careful care, but one has to be aware that in this age group the children are not going to complain. So it's the parents who need to be alerted, pre-op as well as post-op. And for example, you just guide them that if you find there's any change in the visual behavior, they're unable to focus, or there's some increase in the tears or discharge, some little whitishness appearing, constant rubbing, or the eye becoming a little smaller, or if you start seeing an abnormal whitishness, or if you have increased sensitivity to light, all these things are important to mention to the parents right in the beginning. So as I said before, multidisciplinary approach, and the cataract, the keratoplasty, secondary glaucoma. Largely it is, as anterior segment surgeons, we can manage the cataract, the glaucoma, and we have a reasonable knowledge of squint and amblyopia. It's the glaucoma which is a little difficult for us. So you do need a very good glaucoma expert who can help you with that. Sharing some insights into regarding pediatric cases. The other important thing is the multiple interventions that you do. There is, even if the intraocular pressure is not high, the repeated interventions themselves can also lead to a progressive increase in axial length, and there can be a myopic shift. And the other thing is talking about the time to intervene. So ideally we would like to intervene as early as possible, 3 to 6 weeks. However, sometimes the children are not fit for surgery, they may not be fit for anesthesia, they may be having systemic problems. So therefore the window of up to even 6 to 12 weeks is acceptable when you're talking about corneal disease. There is better stereopsis and bilateral congenital cataract from the unilateral counterpart, as we know, and from that learning one would be tempted to have very early intervention for keratoplasty as well. Now, keratoplasty in pediatric keratoconus has good outcomes but can encounter frequent suture-related concerns. Now, in pediatric keratoconus, now we have shifted from PK to anterior lamellar keratoplasty. That has made a lot of difference in the outcome. But not to forget that here again we do have the suture-related problems. So it's very important to make sure you have a protocol for having the patient come back and immediate attention if any such event occurs. The other important thing is that you have associated problems. So, for example, you can have patients with severe VKC, and you have to sometimes really balance their intervention. So, this little child would often come with extremely severe VKC, and to the extent that one was thinking that one's going to have to intervene, repeated inflammatory keratitis, and not to forget that in such situations, one may use a lot of steroids, and that is important to emphasize that you must come back for follow-up and never prescribe steroids in an open-ended manner. Always prescribe them with a defined frequency, duration, and do say review, and even mention stop, because there is a tendency that otherwise I think we can continue putting this for long. And here again we have an example of a clear graph, but if you can see that there's a divergent squint, so it's very important to emphasize the importance of patching and refraction. Similarly, you have patients coming with trauma, and this is a child who had PK at the age of 3 months, and so many years later, and initially unilateral PK was considered not at all worth doing, but that is not so the case today. Here's an example of VKC with a shield ulcer, and if the child is treated with AMG, you can avoid keratoplasty. So you need to have a holistic view. Another child with firecracker injury and has been treated promptly. So just a little bit about pediatric cornea, restoring vision. The other thing is that we also need to be aware about from the past the fact about the increased risk of rejection, failure rates, and poor visual outcome is what is generally used to be accepted. Now let's talk about the increased risk of rejection. So from the past, we should know what is the rate of rejection. We know it's high. There's no doubt about that. Now the timing of surgery, again, there is no general consensus depending upon which way you look at it, but as of today, as early as possible. Regarding the challenges during the surgery, Vanati will be covering that. Outcomes, when you look at the outcomes, even in high industrialized nations, they have found that the results cannot be universally successful. So if you feel an optical iridectomy would give you a better outcome, that is an option that you could consider. But what we would like to look at here is the overall mean graft survival was about 45 months, but the 1-year graft survival was less in eyes with glaucoma. So that's the important thing. So if they have associated glaucoma, the prognosis changes, and we need to have the glaucoma team on board straight away. And the ones who don't have glaucoma have a better survival. And the overall survival rate was 75% at a year. Now, looking at a study from our center, and half of the patients were able to achieve ambulatory vision. Looking at a publication from our center by Vanati and her team, in this case also there was very good follow-up, a reasonable number of cases, but graft rejection occurred in 12%. But look at what we have what we learned from here. The mean surgery rejection interval was about 10 plus minus 7 months. So as early as 3 months, you have to convey the message that from 2 months to 1 year, you have to keep them on very close follow-up, and the mean rejection treatment interval was extremely high, 10 plus minus 7. So that would mean almost 2 to 3 weeks. So that is again, so I'm just trying to explain that the abysmal results earlier were because that some of these things were not attended to, but by taking care of these issues, one is able to have a better outcome. And the third thing I would mention is also taken to consider the immunization. If they're going to go for immunization, we advise that they step up the topical steroids 1 to 2 weeks before, keep the higher level of steroids for 3 weeks, exactly as you would do as immediate post-op, because that has also made a huge difference. And a successful rejection reversal was 25% in this study because of the late presentation. So the ability to reverse a rejection is directly related to the time at which you intervene. So again, one cannot emphasize more that it's very important to get them to come early. And so this is the other thing that we need to do, monitor and keep looking at the results. Just giving you one example of a patient, because the question question was what should be the workup, what should be the assessment of the intervention, and so on. So this was a 13-month-old baby. She was an adopted child, and they presented with history of whitish opacity, which was noticed since the age of 2 months, initially small in size and progressed rapidly. She was initially diagnosed as a perforated corneal ulcer and treated with topical medication elsewhere, and had been referred. And a preliminary diagnosis of keratomalacia was made in view of being fed with top feeding with diluted milk, and she was treated with vitamin A. She also had coexisting severe anemia and had received treatment for the same. So often we find these babies who are coming with keratomalacia also have anemia. They often have hemoglobin below 10. So the birth history was all right, no significant history, and near total elevated leukomatous corneal opacity with 360-degree superficial vascularization. The other eye had a leukomatous corneal opacity which was peripheral, and the remaining cornea was clear. So the initial impression based on this history was that it was bilateral post-keratomalacia, leukomatous corneal opacity with perhaps anterior staphyloma, and ultrasound was done, axial length, and examination under anesthesia was performed. These were the corneal diameters, and this is the UBM picture. The patient then underwent surgery with the Fleringa ring using Hesburgh-Barron and using the lamellar dissection technique so that you do not enter the AC suddenly and hit the iris. There was a cataractus lens, and the capsulotomy was done, lens aspiration, 3-piece IOL was placed in the bag, donor button put, and this were the histopath findings, and this is the vimenting stain. So finally, the histological profile indicated that it was actually a corneal hypertrophic scar following a corneal insult, possibly by keratomalacia, and it is an atypical presentation. And from literature review, there have been 2 reported cases of corneal keloids, but the unique case highlights the importance of an in-depth history taking, surgical management, and the intervention in one eye, keratoplasty, the other eye just observation with refraction and careful